So thank you for the conference organizers and everyone for being here. I realize it's after lunch, but I'm really going to talk about antiretroviral adherence strategies for women with HIV in the postpartum period. And as a means of introduction, technical advances and high-level policy commitments to eliminate HIV in the U.S. really offer a unique opportunity to make major progress toward patient-centered adherence support, particularly for vulnerable groups where adherence is challenging. And for me, I work particularly with pregnant and postpartum women living with HIV, where particularly in the postpartum period, there's a lot of challenges to continue engaging in care and continue adhering to antiretroviral therapy. And current practices to assess ART adherence are that usually the woman sees the clinician asks how many doses she may have missed within a finite period of time. And this works well if there's trust building, if there is truthful reporting from the patient's point of view. But this has limitations, obviously. You know, people are not always truthful for multiple reasons with their struggles with adhering to antiretroviral therapy. And so technology, and particularly when thinking of ways to enhance adherence support strategies, may potentially be one of the strategies that we can think about when assessing adherence. One, because it can reduce the risk of reported bias, particularly because those are objective measures that we're obtaining from the patient's point of view. But then if they're systematically reported, this provides an opportunity to collect population-based data. And by that, there's also the option of actively identifying those who are higher risk to being non-adherent, and this may inform interventions. And this work actually has been informed from an ongoing clinical trial where we are testing a peer-based behavioral intervention, where we are pairing pregnant and postpartum women with a peer who is someone living with HIV, who's there to provide social support and education and provide adherence support. In our anecdotal experience, it's been we've had a large number of women who have declined the peer support intervention, mostly because they felt that they didn't have the capacity to engage in sessions, and they wanted something more simple, straightforward, that could sort of meet them where they were. And so we engage in this work really thinking about what are the other sort of low-touch strategies that could be acceptable for women. And so we engage in qualitative interviews from 3 prenatal care sites that are listed here on the slide, and conducted patient interviews, both people who declined and people who completed the peer-led intervention. But also we wanted to have a global picture, so we also engage multidisciplinary providers in the process, and also health insurance payers. We presented the list of potential strategies, and the order was randomized because we didn't want to introduce bias with the order. And as a hypothesis, we said, okay, just hypothesize that cost or access wasn't an issue, because we really wanted to get at the attributes of those strategies. So this is a busy slide, but I'll sort of walk you through it. So compared to current practice, the first option would be to have a signaling pill where the woman would ingest the ART, which would have a pill sensor that would be programmed with a smartphone, and the data would be automatically provided to the care team and the patient, and there are also reminders with these strategies. The other option would be to have a signaling pill bottle where the bottle itself flashes when it's time for the woman to take the pill. And when she opens the cap, then there's a message sent to a computer system, and the data can also be shared with the care team. Then the video check-in with the provider, so the provider calls and observes the patient through a video platform to take the antiretroviral therapy. So it's a form of direct observed therapy in a way. And then the video check, which instead of having the provider, it's really an automated computer with facial recognition that also has the ability to recognize the patient and the pill taking. And again, the record is automatically shared. And then more traditionally, text messaging that would be sent through the clinic, reminding patients to take their meds. But this would be a two-way contact where the patient would also report taking the medication. And at the time when we started those qualitative interviews, the long-acting injectables were just, in the midst of being rolled out, and we added that as an other option. Obviously, now we know that it's not an option in terms of strategy; it's actual treatment. But we added that in the list. Okay. In terms of data analysis, for the interviews, we use a modified grounded theory to develop the coding structure because we really relied on the consolidated framework for implementation science, which integrates an interdisciplinary approach when thinking of attitudes, considering all the different strategies, and taking stakeholders' perspectives. And we applied the coding structure to all of the transcripts. So in terms of the results, starting with text messaging, this was actually the preferred option for on the provider's standpoint. They really liked it because access is not an issue. Everybody has a smartphone. Everybody knows how to text, and they thought that it would allow more frequent interaction with the patients and perhaps build more trust when thinking of adherence assessment, and particularly for younger patients where adherence is usually a bigger issue, that it would be more attractive. In terms of challenges, they really thought that at some point there would be a response fatigue. One provider said, my general experience is that after 2 to 4 weeks, they began to ignore text, and this is text reminders, and this is one of the case managers who does provide a lot of text reminders to her patients. And then there were also concerns about unwanted disclosure, and really thinking about how to customize the reminder text messages so that if someone else sees the phone, that it's not a concern. The second option in terms of the video check with the providers, in general, the patients and the provider felt that it would be a great way to create a human connection. They really liked that aspect of this strategy, and they thought it would be particularly useful for newly diagnosed clients and for direct observation therapy. But they also felt that it couldn't be a sustained strategy, but it would be a good temporary tool that could help establish adherence and then move on to something else. Some of the challenges that they mentioned was that not all patients or individuals have access to a video capable device. This would create a lot of demand on the care team who would have to initiate those calls, and that at some point it may be cumbersome to patient. And then there were additional concerns regarding privacy and stigma. So one participant said, with our population, with the stigma and all of it, I don't think that'll work because if somebody is watching a patient take a pill, the patient probably will feel violated. So that was the concern. Now with the automated video check, again, that's just a call from the computer with the facial recognition technology. This was actually attractive to clients who didn't want the personal touch and just wanted to have something quick in terms of a check-in. And on the clinic point of view, it would be less resource intensive, particularly for the providers, and less intrusive for patients. But overall, they felt that this would be a step down from the video calls because people really value the patient clinician interaction and relationship, and that this option didn't offer that. So one participant said this method doesn't offer any of the support that the video potentially could. The video that we usually do is a quick check-in, and there's opportunity for positive reinforcement as opposed to just a video recording. Now the signaling pill bottle, the opportunities that it presented was that people really liked the idea of having a visual reminder. They thought it was a new tool, that it would, some of the patients actually found that exciting and innovative. And the patients particularly liked the fact that there would be no disruption of their routine compared to like the video calls or other strategies, and that it would be less intrusive for them. And the data, again, is automatically captured and shared to the patient and the team. But there were concerns regarding privacy. One clinician said anything that would draw attention to the medication would be something they would want to avoid, particularly in a setting where someone's just leaving the medication bottle in a pill in a cabinet and somebody else would see it. So storage came up as an issue, and not having it in a visible location, which again, it defeats the purpose of having the signaling pill bottle. The signaling pill actually was the least preferred option for both the patients and the providers. But in general, they felt that it would be ideal for individuals who are chronically non-adherent. They like the accuracy that would come with the data, that the pill is actually being ingested, and the data is automatically captured. However, there was a lot of concern about safety, about side effect. One patient said, what if I get constipated? What if it gets stuck? That would be running through my mind. So there was a lot of anxiety about swallowing this pill. And a lot of individuals, a lot of the participants also mentioned that this would be a form of invasive monitoring compared to the other options, and that this would threaten the patient-provider relationship. And then lastly, not surprisingly, the most preferred option for women was the long-acting injectables. One woman says, it's way more convenient. I'm tired of taking medicine. So if I could get a shot, that would actually make my life much easier. Also, the opportunity of reducing stigma. Another participant said, you just feel freer, like I feel like the pill is a daily reminder of your situation, and every time like you have to think about like, this is what I'm dealing with, I feel like with the injection, it's like you don't have to think about that as much. And also the less intensive reminders, again, people have to be reminded to come to the clinic, but not to take a pill once a day. They have to remember one appointment once every 2 months. So that was essentially very what we found. In terms of the implementation determinants, we looked at the factors outside of the clinic, which is the outer setting, and they're listed here. They really relate to social determinants. Factors in the inner setting that would help facilitate integration of those technology-based adherence strategies, and they really relate to human resources, the available clinic workflow and how that would need to be adjusted, the integration of the data in the electronic health system, and who would actually pay attention to all the data that's coming in. And then on the individual standpoint, cognitive and physical demand, issues related to postpartum depression. So in conclusion, anticipated barriers to acceptability really varied by strategy and population and included concerns such as perceived surveillance, invasion of privacy, potential for unintended disclosures, resources required for implementation at the clinic, impact on the patient-provider relationship. And anticipated facilitators of acceptability varied by strategy and population. And what I didn't really speak about were, we presented the strategy as they were, but a lot of people really talked about customizing each of those strategies and maybe pairing them sequentially to sort of support patients. And lastly, I'd like to acknowledge the funders, the co-investigators, and of course, the research participants. Thank you so much.